Cook with Zach Healthcare Communications, and I'd like to show our audience how to send in your questions throughout our webinar. Our speaker will try and answer as many as possible at the end of the presentation. Please type your questions into the Q&A box located on the right-hand side of the screen. You can also download the handout from the handout section of the control panel. I'd like to introduce our moderator, Amy Garrett. Amy is currently an ICU nurse educator at Cookeville Regional Medical Center in Cookeville, Tennessee. She has recently presented at the AACN National Teaching Institute, Denver, Colorado, on influencing the performance of nurse-led early mobility behaviors in critical care. In 2021, Amy published a study in the Heart-Lung Journal on a multi-site study of multidisciplinary ICU team members' beliefs towards early mobility. She has been a member of the AACN for several years and holds a board position on her local AACN chapter. Welcome, Amy.
Thank you, Tracy, for the kind introduction. The title of our webinar today is Moving, 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 Early Mobility in ICU and Acute Care. Speaking on this very timely topic is my colleague, friend, and expert on the topic, Heather Davenport. Heather has been a critical care nurse for 25 years. She was the cardiovascular clinical nurse educator for 3.5 years and recently promoted to the director of cardiac step-down at Cookeville Regional Medical Center. Heather has worked with CVICU, cardiac step-down, and cardiac outpatient procedure units. Additionally, Heather provides clinical education for staff in all aspects of medical and surgical cardiac care, including Impella, intra-aortic balloon pump, CRRT, arrhythmia, and hemodynamics in multiple modalities and technologies. Heather is also the president of her local AACN chapter. Our speaker has disclosed no conflicts of interest associated with this presentation. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. Please see the accreditation statement below. This activity is supported by an education grant from Dell Medical Products. Now, I will turn the presentation over to my friend and colleague, Heather Davenport.
Good morning, everyone. Thank you so much for joining us today. We are going to talk about moving, early mobility in ICU and acute care. So hopefully today, after this presentation, you'll be able to talk and describe some of the advantages and obstacles to early mobility in ICU and acute care, discuss the ICU Liberation or A to F bundle in relation to the updated 2025 Society of Critical Care Medicine PADIS prevention guidelines, and discuss how evidence-based mobilization protocols can improve patient outcomes. So let's talk about some not so fun facts. I think I skipped a slide. There we go. So 83% of patients stay in the hospital is spent lying in the bed. There is an underrecognized epidemic of low mobility during hospitalization in older adults. On average, critically ill patients lose nearly 2% of skeletal muscle during the day, the first week of an ICU admission. During a hospitalization, 22.8 hours a day is how much time the patient is in the bed or is doing basically nothing, just some sedentary behavior. So that's only 1.2 hours a day that they are up, that they're walking, or that they are mobile. Also, prolonged ventilation is an independent predictor of ICU-acquired weakness. Ventilator-induced diaphragm dysfunction occurs in 80% of ICU patients on the ventilator. Muscle strength drops 3 to 11% for each additional day of immobility, and at 40% reduction, the mortality rate increases significantly. Critically ill patients are 10 times higher risk for developing a hospital-acquired pressure injury due to hypoperfusion, inadequate tissue oxygenation, poor nutrition, and immobility. HAPIs, hospital-acquired pressure injuries, especially in critical care patients, can be very difficult to heal. So, can we do better? We have to do better, y'all. Moving definitely leads to improving. So if you're not familiar, we have the PADIS guidelines, which I'm going to spell out for you. Then there's the A to F bundle. Those are very much intertwined, so you can't have one really without the other. So let's break down a little bit what that is and what those guidelines are. So in 2018, the initial PADIS guidelines came out. The P stands for pain, A is for agitation and sedation, D is for delirium, I for immobility, and S for sleep disturbances. So let's break that down just a little bit more. So basically these guidelines set up some clinical questions and interventions aimed specifically at critical care to help improve outcomes related to these specific areas. It includes pharmacologic as well as non-pharmacologic strategies to help our patients. So with pain, we're going to look at assessment. Can the patient self-report? What behavioral signs are they exhibiting? What physiological measures are they exhibiting and what changes can we make with that? It looks at analgesia, certain types of protocols that give us the best patient outcomes, any procedural analgesia, and then some non-pharmacologic strategies such as music, relaxation, massage, that type of thing. In regards to agitation and sedation, the key focus really with that is light sedation versus deep sedation. And are we having to use physical restraints on the wrist? Hopefully just the wrist, not 4-point restraints. We're going to look at a daily sedation interruption. At my facility, we call it a sedation vacation. Then we're going to look at the different medications related to agitation and sedation, and then what tools are we using to monitor that as well. With delirium, look at the risk factors, what's going on with the patient, how awake and coherent are the patients, and then do you have a good assessment tool to help you predict delirium occurring in your patient? What medications do we have to treat and prevent delirium, such as Haldol, dexmedetomidine, ketamine, some non-pharmacologic strategies. The A to F bundle goes into that a little bit more, and we'll discuss that momentarily. In regards to immobility, are the patients in the bed, out of bed? Can we do some range of motion? Are we getting PT involved? When do we start this? When do we stop this? Are there screens? What's going to keep our patient safe and what's going to help us as the providers and the care team be safe as well? And what's the potential harm for the rehab and mobilization? And then with sleep disruption, we're going to look at the assessment, ICU sleep versus a healthy sleep, and what is the prevalence of an unusual sleep. So just kind of a side note, I don't know about y'all. If I'm not at home, I don't sleep as well. I think we take for granted that our patients in ICU, just because they're sedated, they sleep well. Unfortunately, they don't. So what can we do as part of the care team to help improve that as well? So the risk factors, are they in ICU? Where were they before ICU? What medications can we use to treat that and help them sleep better and get true sleep, such as melatonin, dexmedetomidine, and propofol? And then some other things such as aromatherapy, essential oils, diffusers, noise reduction, music, and that sort of thing. All right, so this is just a screenshot, and these slides will be available at the end of the program. But this is just a screenshot for the clinical practice guidelines and then the focus update for those clinical practice guidelines for 2025. So it's the Society of Critical Care Medicine, and they have a whole team that looks at this protocol and the guidelines and looks at all the evidence to get this out to us so that we can better take care of our patients. So in 2025, in regard to pain, there really weren't any new updates compared to 2018. For agitation and sedation and anxiety, there was insufficient evidence to make a recommendation on the use of benzos to treat anxiety in adult ICU patients, but they do suggest using dexmedetomidine over propofol for sedation in intubated patients. The goal is light sedation to help reduce delirium, and we'll discuss that more in a few moments. With delirium, they were unable to issue a recommendation for or against the use of antipsychotics over a usual delirium treatment. With immobility, they do suggest providing enhanced mobilization and rehab. And then with sleep, they do suggest administering melatonin versus not giving melatonin. So we've kind of covered the PADIS guidelines. Let's see how that compares to the A to F bundle. Let's break that down. So the A to F bundle, it's also known as the ICU Liberation Bundle. And when I think of ICU liberation, our goal is to get these patients out. We want to get them better. We want to get them extubated, get them mobile, get them back home and healthy to their families. So the ICU Liberation Bundle, or A to F. The A stands for Assessment, Prevention, and Management of Pain. B is both spontaneous awakening trials and spontaneous breathing trials. C, choice of sedation and analgesia. D, delirium assessment, prevention, and management. E, early mobility or mobilization and exercise. And then F is family engagement and empowerment. We have the conversation here when we present this to our staff. We throw a G in there for good sleep. So you're welcome to use that at your facility as well. All right, so let's break this down a little bit more. So assessment, prevention, and management of pain. Obviously, our goal is to assess the pain. If the patient is nonverbal or cannot self-report pain, then you need to be using, at this facility we use is the CPOT, the Critical Care Pain Observation Tool. You just need to make sure that the tool that you're using is what is recommended. If you can't see the pain necessarily, the patient can't verbalize that to you, assume that it's there. When you're physically doing your assessment, what is their heart rate? What is their blood pressure? If the patient's tachycardic, we know that tachycardia is a compensatory mechanism and pain is a huge factor in that. So what clinically does your patient look like that they may be exhibiting unspoken signs and symptoms of pain? If we want to prevent the pain, if you know that the patient has multiple wounds, or maybe they've just been in the bed for a long time, we got to do wound care. We're removing some devices like chest tubes, balloon pumps, and pellets, whatever that may look like. Pre-treat, assuming that your vital signs will support it, pre-treat and pre-medicate that patient with pain. If you don't have an order for pain medicine, please don't hesitate to ask the provider. If that was me or my family, I would absolutely want some medication to help me tolerate that potential painful procedure or movement as well. So when we look at the management of pain, IV opioids are considered the first line. As we were taught in nursing school, we're going to start low and slow before we move up to a continuous drip. And this is no different. We're going to start with an IV push first, and then you can advance it to a continuous drip if necessary. Another factor that we need to look at are their home meds. Is this patient someone who has chronic pain and takes opioids, anxiolytics, something at home that perhaps we haven't started back yet? So not only is their pain more out of control than usual, but there is the potential for them going into withdrawals. So those are things we want to avoid. So let's try to nip it in the bud from the front end. So this is just a screenshot of the CPOT documentation tool that we use at my facility. The CPOT assesses the facial expression, body movements, muscle tension, and then compliance with event or vocalization. And that's going to give us a score that the nurses can treat accordingly. All right, so B is both spontaneous awakening trials and spontaneous breathing trials. The next few slides, we're going to kind of walk through the protocol that we use at our facility. And I can tell you it does work very, very well. So with the spontaneous breathing trial and spontaneous awakening trial, if the doctor or provider puts in an order for no sedation vacation, that is only good for one shift, one 12-hour shift. It's not something that's going to go on forever and ever. The doctor has to put it in every day. And that's kind of a reminder to them saying, hey, is this really needed? If so, absolutely, that's what's best for the patient, but that's not always the case. Doing the SPT and the SAT is going to give us a reduction in ventilator days, a reduction in the amount of sedation as well. And a couple other things that's going to help us reduce our ventilator days. We're going to hopefully do some excellent oral care with the swabs, the sponges, brush the teeth, scrape the tongue, really clean the mouth very well. That's going to help decrease a ventilator-associated pneumonia or a VAC, a ventilator-associated complication. Head of the bed needs to be elevated 30 degrees. The suction canisters need to be changed at least every 24 hours in PRN. We're going to optimize, not maximize, but optimize that sedation and analgesia. And then, of course, PUD and DVT prophylaxis accordingly. Just a little lag here. All right, let me back up one slide just a moment. Okay, we'll go from there. So this is part of the wake up and breathe protocol that we have here. So the flow chart that's on the left-hand side of your screen literally comes from the wake up and breathe trial that was done. I can have the references if you would like them, but this is almost verbatim from that. So evidence-based practice gives us the best patient outcomes, right? So a sedation vacation screen and a sedation vacation, if the screen is passed, is to be completed every single shift by the nurse. The spontaneous breathing trial screen, and then the spontaneous breathing trial, if the screen is passed, is to be done by respiratory therapy daily. Tracy, there's a lag. There it goes. Okay. So again, this is just kind of breaking down that screen a little bit more. If the patient is on any infusion for active seizures or alcohol withdrawal, we're not going to do a sedation vacation screen, or we're not going to do a sedation vacation. We want the patient to be calm. If there's agitation, we're not going to do the sedation vacation. The patient cannot be on any paralytics. There is to be no evidence of acute myocardial ischemia in the past 24 hours and no evidence of increased intracranial pressure. One caveat for us, so my background is the cardiac ICU, so fresh post-op heart patients. We do not use this protocol from the get-go once they're post-op. If the patient that is post-op cabbage or valve cannot get extubated in 24 to 48 hours, then we do revert to this to help them get extubated. If once the patient is able to tolerate the sedation vacation, then the nurse will look and assess the patient essentially. Does the patient have sustained anxiety and agitation or pain? Is the respiratory rate up? Is their sat dropping low? Are they tachycardic? Maybe they're bradycardic. I've seen some patients have that response as well. How is their work of breathing? Are they taking big, deep breaths and moving their shoulders and using their accessory muscles? Are they sweating? Are they pale? Is there marked shortness of breath? And then, of course, any acute arrhythmias. If any of these things occur, that's the end of the sedation vacation. We'll restart that and medicate accordingly. This is just an example, and it's very similar, but this is the SBT screen that the nurse and respiratory therapy will use, and it's very similar to the screen and the protocol for the nurses exactly. So is the patient agitated? What's their SAT? What's their O2 requirements on the ventilator? What is their PEEP? What is their inspiratory efforts? This specifically mentions no recent escalation of vasopressors with the evidence of hemodynamic instability. This is the catch with that. This is in the guidelines, not so that you can say, oh, my patient's on 2 to 4 mics of Levophed or Norepi, I'm not getting them out of bed. Y'all, if they've been on that same amount for several hours, for several days, that's not a reason to not mobilize this patient. If you're on a vasopressor and you see that you're continually increasing that, that is a cause to pause just a moment, let's reassess the situation and consider mobilizing that patient later. And then you can see if the patient fails, the respiratory rate is going to be up, it's going to be low, and again, those same signs of respiratory distress that I mentioned previously. All right, so let's talk about choice of sedation and analgesia. So analgesia is the first line therapy. Okay, we want to make sure that pain is controlled, and our goal is to do that with IV pushes or slow intermittent boluses at first, and maybe that's all it's going to take to help keep your patient calm, not climbing out of the bed on you. But if that doesn't work, then hopefully you have a protocol in place to increase that to a continuous drip. Sedation and agitation orders, that's really a second line therapy per the recommendations. We only want to add sedation if the analgesia alone doesn't get us to our target. At our facility, we use a Riker score. So 4 is our target. If that patient is a 4, then they might be a little bit sleepy, but they can wake up, they can follow commands, they're cooperative. If they're a 5 or a 6, then they're a little bit more agitated, they're not going to cooperate, they might be pulling at the lines and tubes. So our goal here is a Riker of 4. That's that sweet spot. Again, with analgesia, some of the things that we're going to choose first would be fentanyl, morphine, or even Dilaudid. Those things can all be given IV push and then changed to a continuous drip if needed. In regards to, I mentioned earlier that sedation and agitation, the drips, are going to be secondary to the analgesia. Propofol or Diprivan, dexmedetomidine, those are the first 2 choices that the Society of Critical Care recommends. Again, here we're going to use them if our Riker is greater than 4. Please be cautious if you haven't used propofol before. It is egg and soy based. It looks like lipids. If most patients who have a true egg allergy, it's like a real allergy. So please be mindful of that because propofol, it looks just like lipids. Precedex is a wonderful medication. It can be used in ventilated and non-ventilated patients. So it works very well for agitation as well. Midazolam, really, we only want to use that if the patient's having withdrawal from something or they're having seizures. That's kind of a 3rd line option if the propofol and the Precedex aren't doing what we need them to do. So our goal, optimize analgesia, add sedation if the agitation persists, and always use intermittent dosing before we use our continuous drips and infusions. So going to hit just a couple highlights. These are some non-opioid options from the PADIS guidelines. The one I want to point out is gabapentin. Don't know if you're familiar with ERAS, that is early recovery after surgery. There's a couple different arms of that, specifically the ortho and then the post-cardiac surgery arms. Both of those arms obviously is facility dependent, but the general ERAS guidelines strongly support multimodal therapies for pain control. Gabapentin is a great medication for that. It's something that can be started pre-op, it's continued after surgery, and then maybe a week or 2 after the patient goes home. That the research on that tends to show that they require less opiates after surgery for that because it helps deal with that neuropathic pain. And then music therapy. Music therapy is a great thing. We have in our ICU, we have some very musically inclined nurses and educators, and I have personally witnessed them pull out a guitar, get their mobile keyboard, and literally go play and sing with the patients and the families. And the relaxation and just the calmness that comes in the room is truly amazing. So if you don't have somebody that's musically inclined on your staff, then maybe it's going to be the patient's favorite music channel or some CDs or something, because that can be very comforting to them and help manage that pain and sedation, agitation as well. All right, and we've kind of already discussed this, but if it's acute pain, we're going to treat it with an IV push. Fentanyl seems to be the drug of choice. If it is persistent and recurrent, we can always start a drip for breakthrough pain. If it's chronic opiate users, make sure that we are, 1, looking at their home med list, but 2, we can consider ketamine for that. That seems to be a good medication to help control the pain. And then once the patient progresses through their ICU stay, we can always look at transitioning from an IV medication to an oral medication as well. And remember, like we were taught in nursing school, we're going to start low and slow with IV pushes and then increase to the infusion as needed. Once we give it, we can't take it back. So please be cautious with that. All right, we've already discussed this. This is just kind of some highlights more from the PADIS guidelines. Again, notice that last bullet point, acute agitation in non-intubated patients, start with a low dose intermittent IV push opiate. You can use Haldol, but you can also use dexmedetomidine. Don't overlook the Precedex or the dexmedetomidine. Again, it works very well in intubated and non-intubated patients. All right, so what happens if we don't have adequate sedation and pain control? I would venture to say that most of us have probably had those interactions with the patients. I think it stresses the nurses and the care team just as much as it stresses the patient out. We're going to have increased anxiety, increased pain, increased in our ventilator fighting, dysynchrony, if you will, increased agitation, the patient's pulling and trying to reach the tubes. And unfortunately, this means we're going to have to restrain the patient just for their safety, because obviously we don't want those tubes and lines to come out. But that increases your myocardial workload, your respiratory work, and of course, it doesn't help the family either because they can get upset when they see this in their loved one. So the flip side of that coin, what happens if with excessive sedation? So I grew up as a nurse when if the patient was intubated, they were snockered. They had high doses of sedation, they have high doses of pain medication. Like we didn't wake them up for days. Y'all, I'm thankful that the guidelines changed, and I'm thankful for evidence-based practice because clearly what I did 25 years ago as a nurse isn't quite appropriate today. So excessive sedation, increase their ventilator time, increase their ICU length of stay. Maybe they'll have to be trached, increases their chances of DVTs, increases the chances of a VAP or a VAC, increases the added cost, increases the chances of a happy. None of these are things that we really want to occur in any of our patients. So Dee, let's talk about delirium for just a moment. So delirium is experienced by 50 to 80% of mechanically ventilated patients. Y'all, that is a lot. Think of your ICUs. We have our ICU is like 28 to 32 beds. That's a lot of patients, and we're a fairly small facility. And I know some of y'all come from facilities that are much larger. So trying to put like a number and visualize that is kind of mind-boggling to me. So 20 to 50% of those patients result in increased length of stay. Delirium should be routinely monitored in all ICU patients using a validated and reliable delirium screening tool. I'm going to show you one of those in just a moment. And then the screening should be performed at least once a shift or more frequently if there's any changes in mental status. So the CAM ICU assessment, it's the confusion assessment method for the ICU. This was developed by Dr. Wesley Ely. He is at Vanderbilt, has a whole team on it. There are excellent, excellent resources regarding this if you don't use this specific tool to help you evaluate for delirium. Like with any good tool, the tool is only as good as the nurse using it. So you have to use it. So the CAM ICU assesses 4 features when it's assessing for delirium. We're going to look at acute onset of mental status changes or fluctuating course, inattention, disorganized thinking, and an altered level of consciousness. So look at a couple close-up screenshots of that. So I mentioned the acute change or fluctuating course of mental status, the inattention. Essentially, has the patient, is there a change in their baseline? Or maybe it's fine now, but it wasn't earlier. And then you can see there with the inattention, you're going to ask them to say some things, spell a word to see. And basically, this is just an algorithm to help walk you through the assessment for delirium. And this is the 3 and 4, the altered LOC and disorganized thinking. So I like this mnemonic. I like things that are going to be short and sweet and help me remember the things that I need to take care of my patient. So stop and think. Especially you look at the patient populations, most of them are elderly. And we know that their medications tend to last and linger a little bit longer than it would in someone who might be younger. So with delirium, stop and think. Stop any medications that we think might be interfering. Do we have medications that need to be decreased? Are they getting a daily sedation vacation? Are we reaching that targeted plan, that rocker of less than 4 or 4 or less? Are they maybe instead of propofol that we need to be on Precedex? So you have some things to think through with that. So, and then the T is toxic situations. Are they in multi-organ failure? Are they dehydrated? Do they have acute kidney injury? Maybe granny's been at home with nausea, vomiting, and diarrhea. We come in and she has a UTI, and bless her, she's lost as last year's Easter egg and don't know what's going on, but we need to rehydrate her. So that's something that we can, with the doctor's assistance, we can take care of to get her better. Is the patient in shock? The H is for hypoxemia. I is infection and sepsis. We just had sepsis September, so hopefully that's on the forefront of your brain as well. N is the non-pharmacologic interventions. Maybe granny needs her hearing aids because she can't hear. Does she have their glasses? Need to reorient her. What is her sleep habit at home? What are we doing here to help her sleep better? Do we have a quiet time? Can we play some soothing music? Can we get her up and mobilize her? And then K is potassium or your electrolyte disturbances. So some modifiable risk factors with delirium, we've already mentioned some of those, the glasses, the hearing aids, the immobility, the medications. The one thing I want to point out on this is the metabolic disturbances. A CV surgeon that I used to work with, he's an excellent doctor. One of the things he used to tell us all the time was acidosis kills. And it is so very true. If you're doing everything else you can to manage this patient and you're just something's just not quite right, get an ABG, assess your acid-base balance, because he was right. Acidosis can kill. You correct your acid-base balance, some of those medications will start working a little bit better. Hopefully the mentation will come back around as well. Then some of the non-modifiable risk factors, we have if they have baseline dementia or any cognitive impairment, depression, any tobacco and alcohol use, and then any history of stroke or other comorbidities. Okay, next, Tracy. And this is just an example of the quiet time posters that we have here. We have specific time set aside in our ICUs specifically so that we turn the lights down, try to give a dedicated quiet time to help our patients rest and actually get some good sleep. Next. Have you considered that immobility actually causes harm to your patients? Next. So let's talk a little bit about early mobilization and exercise. So early mobilization in critically ill patients has been shown to be safe and feasible in both adult and pediatric populations. Studies show that ICU-based early mobilization decreases delirium, improves functional outcomes, and is cost-effective. From a cardiac standpoint, we're going to increase that venous return, going to aid in weaning those vasopressors, decrease the chances of a clot. If I have a clot in my leg, there's a good possibility that clot can move up to my lungs. So mobilizing, we're going to decrease the risk of hopefully getting that PE, decrease the risk of pneumonia. Patient's going to have to breathe, take good deep breaths, get that diaphragm moving, expand the lungs, improve the oxygenation. And then, of course, if we get them up and moving, decreases the chances of any skin breakdown that might occur as well. Next. Neurologically, how many patients have you had that are just a little bit confused and they're nitpicking at stuff? And if you've been on the floor, maybe even in a nursing home, you give them some washcloths to fold. It works very well, simple, but it's effective. Mobilizing the patient has that same effect. Get them up and walk them. Let them talk to the staff if they can. If the patient's intubated, we'll talk about that momentarily as well. If they're intubated, get them up. Have cheerleaders around them. Let them look around and see. It's going to get the brain going and hopefully decrease some of that delirium and depression. And then we're mobilizing them. So we're working those muscles. It's going to help on balance. It's going to help prevent some of the deconditioning, help prevent some of the pain. We're going to wear these patients out so they're going to sleep better. So it's a win-win for everybody. And then, of course, the gut. Got to keep the gut moving, right? So moving our patients going to help increase gastric motility and decrease constipation and ileus. Okay, next. So not going to go through all the details of this. This was a random controlled trial of 104 patients where they looked at the ability to perform 6 activities of daily living and walk independently at discharge. And the outcome was that safe, well-tolerated, improved functional independence and discharge, removed delirium, the delirium duration, and they had more ventilator-free days compared to standard care. Next. All right, if you're a nerd like me, this is some of the data. So all this is telling us is that by moving our patients, ventilated or unventilated, getting them up, moving them, helping do the ADLs and all the things, it's going to literally have half the amount of delirium days. The intervention group that had the mobility compared to the control group only had 2 hospital delirium days versus 4. The intervention group had only 23 ventilator-free days compared to 21 in the control group. And then overall, the length of stay in ICU, the intervention group had 5.9 ICU days versus 7.9 in the control group. So the overall synopsis is absolutely, we got to move these patients. It gets them moving, it gets them up, it gets them well faster. Hopefully we can get them home sooner. Okay, next. Okay, so who do we need to mobilize? Who do we not need to mobilize? How do I know when I need to mobilize? So these are some parameters, and please keep in mind, parameters are a strong suggestion, if you will. Everybody is going to be very different. So parameters kind of give you guidelines. They're not concrete, they're not set in stone. So what is your heart rate? Is it too high? Is it too low? Is your blood pressure too high? Is it too low? What's my work of breathing? What's my respiratory rate? What's my SAT? What's my FiO2? What is my PEEP? Am I able to open my eyes? Can I raise my hands? Can I do the things that my nurse is asking me to do? Now, that nice little red box off to the right. These guidelines are not to be a substitute for clinical judgment. Again, not everybody's going to react the same. Maybe they're on medications, but maybe they're on a beta blocker. Beta blocker can mask tachycardia. That's the nature of the beast. So maybe you're not going to see that in your patient. Maybe you're going to see something else, another sign or symptom that would indicate that this patient doesn't need to be mobilized. When do I need to reconsider mobilizing? So again, these are just some suggestions. If the patient has a new or symptomatic arrhythmia, again, my history is cardiac. If I have a patient that's been, we'll just say in an AFib at the rate of 80s, absolutely no problem, let's get them up. If that patient is new in AFib, they're used to a heart rate of 80, but now their heart rate is 160, I'm probably not going to mobilize that patient at that moment. Let's get that AFib under control before I take that patient for a stroll. Do they have new chest pain, new ischemia, a spinal cord injury, unstable fractures, an active GI bleed? Do you have femoral access, such as a sheath in the groin? Is it a balloon pump? Is it an impella? Do you have a temporary dialysis catheter in the groin? These are less than ideal to have in the groin and try to mobilize a patient. So you have to be very cautious with that. Do they have active CRRT running, or are we up titrating on those vasoactive drips? And like I mentioned earlier, just because you're on vasopressors doesn't mean that you can't mobilize your patients. Use your critical thinking and go, okay, I've been hanging out at 4 to 6 mics of Levophed for several hours. I've not had to titrate, weaning just a little bit. So yeah, I think I can mobilize my patient, compared to I've gone from 4 mics of Levophed, now I'm on 12 over the past 2 hours. Probably not the patient that you want to be mobilizing at that moment. So next. So some of the barriers to mobility, some are the physical barriers. We've mentioned the hemodynamic instability. Oh my gracious, y'all, as some of these pictures show, and you've worked in critical care, the lines, the devices, the drips, the tubes, the drains, all the things that are necessary to keep this patient alive, right? Though, I mean, that's a lot to manage, let alone get up and mobilize, right? The sedation. Do they have a decreased LOC? Do we have the patient too sedated? Any other illnesses or treatments going on? Structural related barriers include limited staff. I know everybody's short staffed. Thankfully, that's, I think, on the mend a little bit since COVID. But maybe you just don't have the staff that you feel like you need to be able to mobilize your patient adequately. Maybe you don't have an early mobility protocol. Maybe you don't have appropriate training or the equipment so that you stay safe and your patient stays safe. Next. And then cultural related beliefs. If there's a lack of buy-in and the attitude associated with that, if I don't think that I should get my patient up and mobilize them, then I'm not going to do that. If I don't think range of motion and physical therapy is important, I'm not going to consult them, right? So that can be a huge barrier, those personal beliefs. Like a staff, patient, family knowledge on the benefits, safety, and techniques with mobilization. And then process-related barriers like lack of planning and coordination. Maybe you're ready to mobilize your ventilated patient, but respiratory therapy is intubating somebody else down the hallway, or they're on a road trip to CT. So you're ready, but they're not. Maybe the same thing with physical therapy. It's just the timing is just not right. Then my favorite, an unnecessary order for bed rest by the provider. It's important to have those conversations with your provider to get them up and to mobilize them. Next. All right, so I'm going to quickly go through this. This is the adult early progressive mobility protocol that we use here at my facility, and we'll just break this down real quick in the next few slides. Next, please. Thank you. All right, so we have exclusion criteria, the safety screen. So much like we've talked about already, if this patient is on increasing doses of vasopressors, new arrhythmias, new ischemia, the FiO2 is greater than 85, the PEEP's greater than 15, the patient's not responsive to verbal stimuli, I'm not mobilizing that patient. I'm going to keep them a level 0. I'm going to turn them. I'm going to do passive range of motion, and I'm going to keep the head of the bed elevated. Next. Hopefully the next time I assess this, and I should mention this, the graphic is on all of our whiteboards throughout our entire facility. So critical care and non-critical care, so that everybody knows what level that the patient is at when they walk in. So I'm a level 0, I really can't do anything. To be a level 1, my goal is clinical stability, and I can raise my arms and help, okay? Head of the bed's going to be up. The nurse is going to do passive range of motion. We're going to turn them, and we can hopefully sit in the bed position, bed chair position for 20 minutes 3 times a day. And to move to level 2, I want to be hemodynamically stable, and we're still going to continue the turning and repositioning. Next. So I'm at a level 2. Level 2 simply means I can sit up a little bit on my own, maybe with assistance. I can dangle. I'm going to get PT, OT in there as needed, but I'm still going to turn, do range of motion, and continue building on this daily. Next. Level 3, I'm gaining just a little bit more strength. So now, 2 days ago, maybe even 2 shifts ago, I could hardly raise my arms, but now, yesterday I was able to dangle, and today with assistance, I can bear some weight and I can get out of bed to the chair. So again, our goal, we're going to do range of motion, we're going to turn, but with level 3, I want to be able to do some weight bearing and hopefully be able to get myself to the chair. Next. And then level 4, while it is the most progressive, if you will, it's not the end. So the goal of level 4, I'm going to build strength and increase my walking distance. I can still get out of bed. Maybe I still need PT to walk with, but I'm getting up more frequently. I can tolerate more, and this just continues to build and build. If today I can walk 50 feet, I'm going to keep working at this so tomorrow I can walk 100 feet. Next. So who and what does it take to mobilize our patients? Y'all, it takes a whole team, a whole lot of people, right? So we have nurses, respiratory therapists, physical therapy, our nurses' aides, and family. That does my heart good to when you're getting a patient up to walk them, and that patient has to look up and focus on somebody, and there's a family member there cheering them on. Come on, Dad, you can do it. You can do it. It helps that patient, and I think it helps the nurses too. Next. So we've already talked about all the lines, the tubes, the bells, the whistles. Y'all, we got to make sure these things stay in place, right? So if you have an ET tube, make sure that that tube is secured and secured well. You need to note where it is located. Where is it at 22 centimeters now, and it's at 22 centimeters later when you get back to the bed and when you walk. Make sure that you're prepared to re-intubate the patient and take care of the patient if that tube becomes dislodged. With a central line or a PA catheter, again, make sure that you assess where those markings are, that you monitor for any air embolism, any arrhythmias. Lord willing, you have a nice bioocclusive dressing over that line, and you shouldn't have any signs and symptoms of infection, but please be mindful if that dressing gets pulled off, that you can watch for that. But hopefully we're going to use a securement device for that as well. Next. Same thing with your NG tubes and other drains. If it's an NG tube, make sure that you've got a good securement device on that, that you note where that centimeter marking, where that is located. If it's Penrose drains or JP drains, use an abdominal binder, wrap them up. If it's a Foley catheter, it needs to be secured with a leg band of some sort as well. Next. And then other assistive devices, gait belts, lifts, walkers, all the portable things, your oxygen, your suction, your telemetry monitor, all of these things. So I'm sure you see why it takes a whole team to mobilize these patients, but they do so well with it, and they're so much better off. All right, next. A couple things. So when I was growing up as a baby nurse, we called it a tilt table. Now they call it verticalization therapy. So we have these fancy beds, as you can see in the picture. It literally turns the bed into a tilt table. And the purpose of that is just to help with orthostatic hypotension and start having the patient bear some weight on their legs as well. There's a cardiac chair position in the bed, and then the actual cardiac chair outside of the bed. Next. And then this is just a summary. As we've mentioned before, with a tilt table or verticalization, it's going to help everything. It helps the muscles. They have to bear weight. They're going to breathe deep, get those lungs expanded, help that diaphragm, help that heart rate, help that heartbeat better. It's going to help our cognitive function. We're going to think, because sometimes if the patient's been really sick, they really have to think about, oh, I got to lift my arms, I got to move my feet, I need to bear weight. So it really gets everything going, and it works very, very well. All right, next. And then family engagement, certainly not to be overlooked. As I said, having the family there as a cheerleader when the patient is up and walking, even when you're turning, explaining to them, including them in all of the patient care. Next. So I have some awesome colleagues. I don't know if I've said that yet. Some other colleagues were actually published regarding the diary that we use in critical care. And the study with that showed that having the diary was a useful tool in stress reduction, information management, and then as a communication tool. So if granny can't communicate, maybe mom or dad, somebody can use that diary literally to document, hey, on day 1, this is what occurred. On day 2, this is what occurred. Because a lot of times, granny or papaw that's in the bed is on propofol, something that gives them amnesia, which we don't want them to remember the bad things. We want to keep them comfortable, but once they wake up, they're going to have gaps in their memory, gaps in that timeline that they need to put the pieces back together for, and a diary is very helpful for that. And if you're not familiar with it, PICS, post-intensive care syndrome, unfortunately, that is essentially PTSD. For patients who experience delirium or are in ICU for a long length of time. Using the diary is one way, again, to kind of help put those parts and pieces back together again. So next. All right. Is it beneficial to follow the ICU Liberation Bundle? Absolutely. Y'all are smart people. I'm not going to tell you all the numbers, but y'all, it's going to decrease all the things that we want it to decrease. It's going to decrease our ventilator days, our hospital length of stay, decrease delirium, decrease any skin and wound issues. So we have to mobilize these patients. It is absolutely worth it. All right, next. All right, so my challenge to you, haven't really discussed a whole lot of acute care outside of ICU. So this is my challenge to you. Do you have a protocol for your non-ICU patients? ICUdelirium.org has the tools, lots of information, but it's not necessarily the whole bundle. Are you proactive with mobilizing your step-down patients? How long is your bed rest order active? 1 shift, 12 hours, 24 hours? Do you question your provider when the lines are placed in a less than ideal location? It's something to ponder, right? So my personal opinion, I think it is equally important to mobilize our non-ICU patients as it is to mobilize our critically ill patients, because regardless of their location, they deserve that same exact standard of care. Next. All right, so finally, moving means improving. Y'all, we have to do it. That's what our patients want. That's what they need. And y'all are excellent nurses. I know you can do it. So let's get moving, moving, moving. Thank you so much, and I'll turn it back over to Amy.
Thank you, Heather. That was a most informative session. I would like to inform our viewers how to obtain their CEs for this session. Continuing education for nurses and respiratory therapists. This activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to www.saxtesting.com/P. You will need to register on the test site. Complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Dell Medical Products, Inc. An archive on-demand version will be available on www.perspectivesinnursing.org. The on-demand version will be accredited for CEs. Now, we will take questions from our audience. We've had many great questions submitted, and we will answer as many as time allows. Okay, so first question, Heather.
Okay.
Do you find pre-op education for expectations post-op helps patient responses? Great question. That's from Julie.
Yes, absolutely. Thank you, Julie. So my background is CVICU, so I did a lot of the pre-op education for those patients. We specifically created a video that went through that. But I think preparing them and telling them this is not a sprint, this is a marathon. So the ERAS guidelines that I mentioned earlier kind of help with that. If they know that they're having surgery or any procedure, we'll say on Monday, and we do pre-op testing and pre-op education 2 weeks ahead of time, go ahead and say, all right, let's start walking. If it's walking to your mailbox and back, if all they can do is walk around through their house, but can make sure that they do it every day, I think that helps them prepare mentally as well as physically. So absolutely, absolutely beneficial.
Thank you. Okay, so next question. Can you elaborate more on changing suction canisters daily to help reduce ventilator days?
Sure, absolutely. All right. If you've been, I think, in the hospital anywhere, and somebody has oral suction a canister set up to suction, and we have a yonker set up for our oral care, it gets pretty gross and grimy looking if it's been sitting there. So in changing those canisters, if they're full, if you just really can't stand looking at how nasty they can be, but at a minimum, changing them every 12 hours, really it's fairly simple. It just cuts down on the germs. It's going to take the dirty away and create a clean environment. So we change the canister, we change the yonker, and we change the suction, the tubing.
All right, thank you, Heather. And that question was from Alicia. Thank you for your question, Alicia. Next question, and this is from one of our viewers. Could you please comment on post-cardiac surgery patients with a low or absent intrinsic heart rate who are connected to a temporary pacemaker? Is it safe to mobilize them up to a chair? This is a multiple part question.
Okay.
This sometimes needs to be done in order to assess chest tube drainage before removal. Also, what about patients who have a PA catheter in place?
Great questions. Okay, so let's kind of break it down just a little bit in regards to having a temporary pacemaker. If it is a transvenous pacemaker that goes through the IJ and it is a single lead, I do not recommend getting that patient up. There's outside of the skin, there's nothing really to secure that internally into the heart, so you increase the chance of losing capture with that pacemaker. If it is post-cardiac surgery and they have epicardial leads, then absolutely In the unit I worked in, we mobilize them all the time. If they're 100% paced, that pacemaker is going to do its job. So absolutely get them up and mobilize them. In regards to a Swan catheter, I'll be fully honest and transparent. Depending on what literature you look at, some say, yeah, absolutely mobilize them. That kind of makes me a little bit nervous. Now, will I get them up very cautiously from a bed to the bedside chair at the Swan? Absolutely. If I'll take it a step further, if they have an Impella vascular access, vascular assist device that is done axillary, sometimes they have a Swan with that, sometimes they don't. Still get them up to the bedside chair, because just the simple act of standing them up, taking a few steps and sitting them down is going to be equally as beneficial at that point in their stay as it would be walking 400 feet. So you got to take baby steps to start. So highly recommend it. Just do it with caution.
Thank you, Heather. Great question. Another question from our audience: how soon do we need to start an early progressive mobility for our patient? And this came from Grace.
Okay, read that again. How soon to start a protocol?
How soon do we start it for our patient?
Oh, from the admission. Because on admission, part of your admission assessment should be how mobile they are. Are they wheelchair bound? Can they walk 2 miles every day at home? Like, what is their initial mobility status? If it is somebody that's having a procedure, kind of the previous question talking about that pre-planning and that pre-education, we have to know their baseline. But once you know their baseline, you should start passive range of motion. You should turn them, get them up. If you need a PT consult, get it all in there. Do it from day one, because in the end, that should also help decrease their length of stay.
Thank you. So next question, do you have any advice for dealing with mobility of unstable patients? It's common in critical care areas to hear patients are too unstable to turn and reposition. Have you encountered this challenge? And if so, how do you deal with this?
Oh, that's a loaded question, but it's very good. And Amy, I'll let you chime in on this as well.
Oh, sure.
So I think you do it cautiously. Obviously, if they're unstable, they may be on multiple drips, multiple pressors, have multiple lines, but we obviously don't just want them laying there. So I think doing some micro movements and slow turning would be very helpful. Amy, input on that from ICU?
Oh, sure. Exactly. I think any movement is better than no movement. So sometimes patients are able to tolerate those incremental shifts in position and micro movements, hyperoxygenation pre and post, spacing out activities that may stress the patient. And these are all good techniques. Again, like you said, Heather, slowly turning the patient, and just seeing what that patient can tolerate, giving them a second to recover, or several minutes actually to recover before you move on to the next thing, and just try to maintain that stability as much as you can for those patients.
Absolutely. And I think doing things slowly is going to be beneficial, not only for the patient, but for the nurse, because you don't want to do something too fast and then it kind of bites you later because it created more instability. So kind of like with the IV push medications, we're going to start low and slow and do it incrementally.
Sure. Thank you, Heather. A couple other questions. Let's see. How do you enforce compliance with your early mobility protocol at your facility?
Oh, wow. So this is a hot topic at our facility. So as you all know, whether it is with mobility, oral care, so many things fall in this category, y'all. I think it comes down to accountability, because regardless of what it is, even though the protocol is there, if you don't have it, if I'm not doing it, doesn't matter that the protocol is there. It's not benefiting the patient. So I think coming down to, it comes down to accountability and educating the staff on the why. Why are we doing this? Why is it beneficial? Because it helps with that buy-in, to get people involved and kind of on the same team.
Thank you, Heather. We do have time for just one more question, and there was a question I wanted us to clarify. Sean asked about ketamine being used on the protocols, and he would like us to elaborate more on the use of this product in the hospital setting. But I would like to clarify that we don't utilize ketamine as part of our protocols. Do you have any more to add to that, Heather?
I don't. That is a provider thing. It is an option for our providers. We typically stick to the fentanyl, the propofol, and the Precedex.
All right. Thank you, everyone, for your questions, and thank you for attending this webinar. I will turn the presentation over to Tracy for some concluding remarks.
Thank you, Amy, and thank you, Heather, for that fabulous session. We'd also like to thank everyone for attending today's webinar. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. As well, for your CE certificate of completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions and a link to obtain your CE credits. That's at www.saxtesting.com/p. This concludes today's session. We hope you have a great rest of your day. Thank you.
Thank you.